Nursing assessment should include information on changes in the patient's health status, sexual function, and sexual relationships as well as the patient's knowledge level and ability for self-care. The extent of the nursing assessment of the male reproductive system depends on the nurse's education, experience, and role in the setting. This section describes a complete nursing assessment, although some aspects may be performed only by an examiner with advanced training. The LPN contributes data for the overall assessment. The interview and physical assessment may be particularly difficult for some male patients because of health beliefs, the need for privacy, or defensiveness about behaviors. It's important to allow the patient to tell his own story and maintain as much control over the environment and experience as possible. Establishing a comfortable relationship with the patient is most successful if open-ended questions are used. The examiner should avoid questions beginning with why, and leave sensitive questions until later in the interview. Although it is helpful to empathize with the patient and gently press for important details, comments on how he should feel or behave are inappropriate. The assessor should not jump to conclusions too early or bias the patient's story by expressing a personal opinion. Health history. Present illness, pain, weight loss, infertility, ED, scrotal mole, penile discharge, lesions. Past medical history, previous injuries, diseases, or surgeries. Chronic illnesses, DM, cardiovascular disease, addictive behavior. Allergies. Current medications. Family history, diabetes, hypertension, stroke, blood disorders, cancer. Review of symptoms, general health state, changes in appetite, weight, activity, self-care, skin, lesions, drainage, bleeding, itching, pain, cardiovascular, edema, respiratory, cough, dyspnea, endocrine, fatigue, heat or cold tolerance, nervousness, nervous, paralysis, genitourinary, changes in urination or urine characteristics, sexual function, interest in sexual relationship, frequency of intercourse, ED, desire to have children, effective sexual function on self-image. Functional assessment, usual day, occupation, home roles and responsibilities, diet, rest, use of tobacco and alcohol, stressors and coping strategies, sexual relationships. Physical examination. Vital signs. General appearance of genitalia, skin lesions or discoloration, hair distribution. Penis, size, shape, skin lesions, discharge, position of urinary meatus, nodules, swelling. Scrotum, color, edema, irritation, presence of testicles, testicular tenderness or masses. Inguinal hernia. Prostate, size, texture, masses. Perineum, color, lesions. Anus, lesions, irritation, inflammation, fissures, abscesses, hemorrhoids, rectal prolapse. Discuss diagnostic test and procedures of the male reproductive system. Semen analysis of the semen may be done to assess male fertility or to document sterilization after a vasectomy. The analysis may include growth evaluation of semen for volume, thickness, color, and pH and microscopic ability to penetrate cervical mucus. The patient is instructed to abstain from sexual activity for 2 to 3 days and then collect a seeming specimen in a clean container. Discourage patients from prolonged abstinence because it may result in diminished quality and motility of the sperm. If the patient is unable to collect the specimen in the physician's office or laboratory by masturbating, it may be collected at home by using a plastic condom or quota interrupted. Rubber condom should not be used because the powders and lubricants used in their manufacture may be spermicidal. The specimen should be kept at room temperature, protected from heat or cold, and brought to the laboratory within 1 hour after collection. Endocrinologic studies. The endocrine system secretes hormones that regulate metabolism, growth, stress response, reproduction directly into the blood. The serum levels of these hormones can be determined from blood drawn from the patient without special preparation. Tumor markers. Tumor markers are substances found in the serum of cancer patients. When used in conjunction with other diagnostics tools, they can be helpful in diagnosing cancer, estimating the degree of cancer development, predicting the effective treatment, and monitoring the effective treatment on the cancer or return of cancer after treatment. Prostate-specific antigen, PSA, is used as a screening tool to detect prostate cancer. However, it can be elevated by many factors other than cancer. Some experts recommend that 2 PSA confirmatory results should be done before any action is taken. No special preparation is needed for these tests. General laboratory studies urinalysis provides information about infection of the genitourinary tract as well as measures of kidney function. Clean cap samples usually can be used unless the patient is unable to collect the end without contamination. If appropriate instruction is given for collection, no other patient preparation is needed if the patient is unable to clean himself properly, cannot see well enough, or is not able to understand when instructions, it may be necessary to obtain a specimen by catheterization. Radiologic imaging studies. Computed tomography may be used in assessing metastatic testicular and prostate tumors. Ultrasound may be used to examine scrotal masses or define prostatic lesions. Examination of the prostate is done via the rectum. MRI is used to stage prostate cancer. Radionuclide imaging may be done to assess testicular abnormality such as torsion, tumors, abscesses, epididymitis, or hydroceles. Ultrasound. Transrectal ultrasound is the most accurate method for obtaining atomic in detail of the prostate. A biopsy specimen may be obtained, guided by the transrectal ultrasound image. Discuss inflammatory conditions, prostatitis, epididymitis and orchitis. Inflammatory conditions. Infections of the male reproductive system may be caused by bacteria, viruses, protozoa, fungi, and ectoparasites that can be acquired through sexual contact. The most common inflammatory conditions are prostatitis and epididymitis. Prostatitis, inflammation of the prostate gland, and the types include acute bacterial prostatitis, chronic bacterial prostatitis, chronic prostatitis/chronic pelvic pain syndrome, and asymptomatic inflammatory prostatitis. Signs and symptoms of acute prostatitis are swelling, warmth, and tenderness. The patient with chronic inflammation may have less dramatic pelvic pain, urinary tract symptoms, and sexual dysfunction. Diagnosis is based on the patient complaints, confirmed by lab studies of prostatic secretions. Acute bacterial prostatitis and chronic bacterial prostatitis are treated with antibiotics, analgesics, muscle relaxants, and sitz baths. A 4-week course of antibiotics is usually prescribed for acute bacterial prostatitis and 16 weeks of therapy for chronic bacterial prostatitis. Epididymitis, inflammation of the epididymis may be caused by infections, trauma, or the reflux of urine from the urethra through the vas deferens. Signs and symptoms are painful scrotal edema, nausea, vomiting, chills, and fever. Nursing care involves monitoring temperature, edema, and comfort. It is treated with bed rest, ice packs, sitz baths, analgesics, antibiotics, anti-inflammatory drugs, and scrotal support. If the condition is associated with a sexually transmitted infection, the patient's sexual partner is treated with antibiotic therapy as well. Orchitis, inflammation of one or both testes. It may be related to trauma or to infections such as mumps, pneumonia, or tuberculosis. Signs and symptoms include fever, tenderness and swelling of the affected testicle, and scrotal redness. The inflammation can lead to reduced fertility or sterility. It is treated with analgesics, antipyretics, bed rest, scrotal support, and local heat to the scrotum. Discuss benign prostate hyperplasia, treatments and nursing care. Discuss care of a patient with prostatectomy and patient teaching. Benign prostatic hyperplasia. Benign prostatic hyperplasia is enlargement of the prostate gland. It is a common age-related change. Signs and symptoms. Signs and symptoms of benign prostatic hyperplasia can be classified as voiding, storage, or postmicturition. Voiding symptoms include hesitancy, weak urinary stream, straining, and prolonged voiding. Frequency, urgency, nocturia, urge incontinence, and voiding small volumes are storage symptoms. Postmicturition symptoms are post-void dribbling and incomplete emptying of the bladder. Patients typically have a combination of these symptoms. Symptoms may be triggered by bladder irritants as well as some drugs. Bladder irritants include alcohol, caffeine, and artificial sweeteners. Drugs that may aggravate the condition are diuretics, decongestants, and antihistamines. Medical diagnosis. A diagnosis of benign prostatic hyperplasia is based on reported symptoms and findings from a rectal examination, endoscopy, ultrasound, catheterization for residual urine, and sometimes urodynamic testing. See Chapter 41. Laboratory and radiographic studies include urinalysis, uroflowmetry, measurement of post-void residual by ultrasound, and serum prostate-specific antigen, PSA. If hematuria is present, cystoscopy may be done to rule out bladder cancer. Medical treatment. Conservative measures can decrease urinary symptoms. These include maintaining fluid intake of 1500 to 2000 ml/day, fluid restriction for 2 hours before bedtime, avoidance of caffeine and alcohol, and some bladder training exercises. See Chapter 14. Drugs that may be prescribed to treat benign prostatic hyperplasia and related symptoms include 5-alpha reductase inhibitors, alpha-1 adrenergic receptor antagonists, alpha-1 blockers, and anticholinergics. 5-alpha reductase inhibitors suppress prostatic tissue growth by decreasing testosterone levels. Examples are finasteride, Proscar, and dutasteride, Duogen. Alpha-1 blockers such as tamsulosin, Flomax, doxazosin, Cardura, terazosin, Hytrin, silodosin, Rapaflo, and alfuzosin, Urixatrol, are used to relax smooth muscle in the bladder, neck, and prostate, thereby reducing obstruction to urinary flow. Anticholinergics include tolterodine, Detrol, solifenacin, Viasicare, and fisoteridine, Tovias. Combinations of drugs are proving more effective than either type of drug alone. See the complementary and alternative therapies box. Surgical and invasive treatments. Surgical or other invasive intervention is usually advised if complete urinary obstruction develops, if evidence of existing or impending renal damage exists, if the patient has repeated urinary tract infections, UTIs, or if significant bleeding occurs. In general, invasive procedures involve surgical removal of all or part of the prostate, prostatectomy, or ablation, destruction, of prostate tissue. Nursing care of the patient with benign prostatic hyperplasia. Focused assessment. The complete assessment of the male reproductive system is summarized in Chapter 53, Box 53.1. Data needed for assessment of the patient with benign prostatic hyperplasia include a complete description of urinary symptoms, frequency, urgency, hesitancy, a change in stream size or force, and nocturia. Record the presence of pain or hematuria and palpate the lower abdomen or use a Doppler to detect bladder distension. If ordered, the patient may be catheterized after voiding to measure residual urine. Interventions. Urinary obstruction. Instruct the patient to void promptly when the urge is felt and to space fluid intake throughout the day rather than consuming large amounts of liquids at one time. A daily total fluid intake of 1,500 to 2,000 milliliters is recommended. Fluid restriction is not recommended because it increases the risk of UTI. However, avoiding fluids for 2 hours before bedtime may reduce nighttime voiding. Notify the physician if the patient is unable to void and the bladder becomes distended. Perform catheterization as ordered. It may be difficult to pass the catheter because of the enlarged prostate. If the catheter does not pass easily, do not force it. Inform the physician. The procedure is usually done by a urologist using special instruments. Fear. Explore the patient's fears and provide information about anticipated procedures and effects. Ineffective management of BPH. Because this condition requires long-term management, the patient or a caregiver must understand how to manage the condition. Advise the patient that over-the-counter, OTC, drugs containing antihistamines or pseudoephedrine, which are commonly found in cold remedies, can aggravate urinary symptoms. See the patient teaching box. The patient should avoid caffeine and alcohol, which have a diuretic effect. Patient teaching. An enlarged prostate compresses the urethra, which interferes with passage of urine. To prevent urinary retention, drink fluids throughout the day. Consult your physician or pharmacist about non-prescription drugs. Common drugs, such as antihistamines, example, cold remedies, can cause urinary retention. Report signs and symptoms of infection, i.e., burning on urination, foul urine odor, cloudy urine, and obstruction, i.e., feeling of bladder fullness, inability to empty bladder, lower abdominal pain. Take your medications as prescribed and notify your physician of any adverse effects. Provide the patient with information about specific drugs. Focused assessment. When the patient returns to the nursing unit, measure his vital signs and compare them with preoperative measurements. Inspect urine, dressings, and wound drainage for excess bleeding. Maintain accurate records of fluid intake and output to avoid overdistension of the bladder. Input and output should be balanced. Record the color of the urine and any clots present. Check intravenous fluids and regulate the rate of flow. Monitor the patient's level of comfort for incisional pain and bladder spasms. Patient problems, goals, and outcome criteria, prostatectomy. Patient problems. Potential fluid volume deficit related to hemorrhage. Pain related to tissue trauma and bladder spasms. Potential for infection related to invasive procedures of the urinary tract and surgical incision. Potential for injury related to obstructed urine flow, excessive absorption of irrigating fluids, trauma to the urinary sphincter. Urge urinary incontinence related to poor sphincter control, bladder contractions. Impaired sexual function related to removal of prostate, retrograde ejaculation, possible neurologic injury. Low self-esteem related to anticipated alteration in sexual function. Lack of knowledge of postoperative routines and self-care. Interventions. Potential for fluid volume deficit. Goals and outcome criteria. Normal fluid balance, balanced fluid intake and output, stable vital signs, consistent with patient norms. Pain relief, patient states pain is relieved, relaxed expression, reduced risk of infection, freely flowing, clear urine. Absence of complications because of obstruction, water intoxication, or sphincter injury. Improved control of urine elimination, patient controls urine passage, has decreasing incidence of incontinence. Management of sexual dysfunction, patient states he understands sexual dysfunction and identifies appropriate adaptations and resources. Improved self-esteem, patient makes positive statements about self. Patient understands routines and self-care, patient correctly describes limitations and demonstrates self-care activities. Restlessness and an increasing heart rate are early signs of fluid volume deficit. Blood in the urine is expected for several days after a prostatectomy, however, the drainage should be light pink within 24 hours. Bleeding with clots can signal hemorrhage and must be reported to the physician immediately. Bright red blood may indicate arterial bleeding that requires surgical intervention. Dark blood may require pressure on the surgical area at the neck of the bladder. To apply pressure, the physician may inject additional fluid into the balloon that anchors the indwelling catheter. The catheter is then pulled so that the balloon fits tightly against the neck of the bladder, and various forms of traction are used, including taping the catheter to the thigh. This traction may be maintained for several hours or more and then released by the physician. Continuous bladder irrigation helps to prevent clot formation and subsequent obstruction that can cause bladder spasms and infection. Hang irrigating fluids, usually normal saline, and regulate flow at the prescribed rate. Pain. Pain after prostatectomy may be associated with urinary obstruction, bladder spasms, and surgical trauma. If urine is not draining freely, reposition the tubing and irrigate according to agency policy or surgeon's orders. Antispasmodic agents such as oxybutynin chloride, ditropan, belladonna, and opium suppositories, or propanthyline bromide, probanthine, are usually effective in relieving bladder spasms. Administer analgesics as ordered and assess effectiveness. See the complementary and alternative therapies box. Potential for infection. To reduce the risk of infection, use strict aseptic techniques when handling urinary drainage, wound drains, and dressings. Keep closed urinary drainage systems intact to prevent the introduction of pathogens. Following an open prostatectomy, provide wound care in accordance with the physician's orders or the agency's policy. Monitor for signs of infection, including temperature above 101 degrees Fahrenheit 38.3 degrees Celsius, purulent wound drainage, and confusion in older patients. Potential for injury. Urinary obstruction and bladder distension can lead to renal complications, i.e., hydronephrosis, infection, and increased bleeding. Therefore, it is critical to maintain urine flow. If urine flow ceases, assess the bladder for distension. If the bladder is distended, temporarily turn off the irrigating fluid and manually irrigate the bladder as ordered. If you cannot clear the tubing, notify the surgeon immediately. After the catheters are removed, you must continue to monitor output because edema or scarring may occur and obstruct the urethra. Urge urinary incontinence. Urinary incontinence or dribbling is common immediately after the catheter is removed. In most cases, control can be improved with perineal exercises. Instruct patients to contract and relax the perineal muscles 10 to 20 times each hour. If control does not improve, the physician may recommend biofeedback, a penile clamp, a condom catheter, or incontinence briefs. In severe cases, an artificial sphincter may be surgically implanted. Some patients never regain full control of urination. For additional information, see Chapter 14. Impaired sexual function and low self-esteem. Alterations in sexual function that may distress the patient include sterility, retrograde ejaculation, and ED. The patient should be encouraged to discuss these concerns with the physician before surgery. ED is not common after surgical treatment of benign prostatic hyperplasia, but if it does occur, the patient may need counseling, as described in Erectile Dysfunction, Impotence, section. No treatment for retrograde ejaculation exists, but you can reassure the patient that it is not harmful. All of these alterations can threaten the patient's self-image and self-esteem. Be sensitive to the patient's feelings of loss and need to assert a masculine image. The patient may wish to include his sex partner in teaching and counseling sessions. Discuss prostatic cancer, treatment and nursing care. Prostatic cancer. Cancer of the prostate is found on post-mortem examination in 30% of men over 50 years of age, and the incidence increases steadily with each decade to 100% of men in the 10th decade. More than 161,600 new cases were expected to be diagnosed in the United States in 2017, and more than 26,000 deaths from prostate cancer were predicted in that year. Although the cause is unknown, the risk factors include age over 50 years, African American race, family history of prostate cancer. Cultural considerations. The incidence of prostate cancer among African American men is nearly twice that among Caucasian Americans. High-risk groups should be targeted for education about the importance of early evaluation of urinary symptoms. Early detection. Serum PSA increases with prostate cancer, but also with a variety of other conditions. Whether PSA should be used as a screening tool is controversial. In 2012, the U.S. Preventive Services Task Force recommended against PSA-based screening for prostate cancer. As of 2018, that recommendation remains the same. The task force indicated that elevated PSA often led to cancer treatment with serious complications for many men whose cancer never would have become life-threatening. On the other hand, the American Cancer Society, ACS, recommends that at 50 years of age, all men discuss with their physician the pros and cons of periodic screening, PSA with or without rectal examination, so that they can make a decision that is right for them. The ACS recommends that African American men and other men with increased risk for prostate cancer initiate this discussion by 45 years of age. Medical diagnosis. Prostatic lesions are typically slow-growing and confined to the prostatic capsule. However, younger men tend to have very aggressive tumors. Prostatic tumors may go undetected until the disease is advanced and has metastasized to bone or liver. Large tumors may cause bladder outlet obstruction, rectal pressure, stool changes, painful defecation, or painful ejaculation. Because early diagnosis may improve treatment results, methods to permit early detection may be advised. The diagnosis may be based on rectal examination, transrectal ultrasound, PSA level, and needle aspiration and biopsy. If a diagnosis of prostate cancer is made, additional procedures may be done to identify the stage of the disease. These may include radiographs, radionuclide imaging, bone scans, excretory urography, transurethral ultrasound, CT, and MRI. Medical treatment. The treatment of prostate cancer is controversial because of the difficulty in staging tumors and the unpredictable biologic behavior of the disease. Treatment options include watchful waiting, radiotherapy, brachytherapy, cryosurgery, and radical surgery. Chemotherapy is useful in limited cases. Sometimes watchful waiting is recommended for patients with a life expectancy of less than 10 years who have small cancers or who are not good surgical risks. The patient is monitored frequently and treatment is initiated if the tumor begins to enlarge. Radical prostatectomy includes removal of the prostate gland, the outer capsule, the seminal vesicles, sections of the vas deferens, and sometimes a portion of the bladder neck. Most operations include removal of the pelvic lymph nodes to check for metastasis. The surgical approach is usually perineal or retropubic. The latter approach permits an autonomic nerve-sparing technique, which may preserve erectile function. The urinary incontinence that occurs in 10% to 15% of men who undergo radical prostatectomy subsides within 6 months in 85% to 90% of those affected. Minimally invasive radical prostatectomy using a laparoscope and robot-assisted technology is available in some settings. It is believed that less invasive techniques will result in less blood loss and less postoperative pain. Radiation alone is often effective when the cancer is confined to the prostate. Radiation can be delivered by external beam or by implanting seeds, brachytherapy, of radioactive gold, iodine, or iridium in the prostate through hollow needles inserted under anesthesia. External beam radiation requires only a few minutes, 5 days a week for 6 to 8 weeks. Side effects include skin dryness and irritation, diarrhea, cramping, and gastrointestinal, GI, bleeding, sexual dysfunction, fatigue, bone marrow suppression, and various urinary symptoms such as dysuria, frequency, hesitancy, urgency, and nocturia. The radioactive seeds affect surrounding tissues less than external beam radiation. Patients often have some urinary symptoms of irritation or obstruction after the seeds are implanted. Newer radiation options include three-dimensional conformal radiation therapy or intensity-modulated radiation therapy. The new procedures deliver higher doses to the target tissue with less toxicity. Prostate cancer growth is influenced by hormones. Therefore, hormonal therapy is used to eliminate the androgenic effect by interfering with androgen production or blocking receptors for the androgens. Testosterone production can also be achieved by removing the testicles. Many men elect drug therapy over the surgical option. Types of drugs used in hormonal therapy include luteinizing hormone, releasing hormone, LHRH, agonists and androgen receptor blockers. LHRH analogs include luprolide, Lupron, goserelin acetate, Zolocard, Buzerelin, Superfact, and triptorelin, Trelstar. These agents inhibit the release of pituitary hormones necessary for testosterone production. They are given intramuscularly or subcutaneously. One form is available in pellets that are implanted subcutaneously and deliver medication for 1 year. With initial therapy, patients may experience bone pain, which resolves over time. Drugs that inhibit the action of testosterone include flutamide, ulexin, bicalutamide, Casodex, and nilutamide, Nilandrin. They may be used in combination with LHRH agonists, see Chapter 53, Table 53.3. The adverse effects of all of these agents can include hot flashes and ED. When these agents are no longer effective, other drugs may be used that reduce testosterone production in the adrenals. Examples are spironolactone, aldactone, aminoglutathione, cytodren, and glucocorticoids. Hormonal therapy is usually effective for a limited period of time, generally 1 to 3 years. Bone pain and fractures are complications of prostate cancer. Bisphosphonates such as alendronate, Fosamax, may be ordered to help relieve bone symptoms. PSA is a useful tool for the follow-up of patients who have undergone treatment. Persistent or rising PSA levels indicate advancing or recurrent tumor growth. Nursing care. Details of the assessment of the male reproductive system are summarized in Chapter 53, Box 53.1. Nursing care of male patients should include encouragement to discuss whether to have periodic screenings for prostate cancer. If the patient has undergone surgery, nursing care is similar to that described in the section titled Nursing Care of the Patient with Benign Prostatic Hyperplasia. Nursing care of the patient with cancer is discussed in Chapter 7, and the care of patients having urologic surgery is discussed in Chapters 41 and 42. Specific problems that may require special interventions after prostate surgery are bladder spasms, ED, urinary incontinence, and body image disturbances associated with changes in the reproductive system. Newer techniques have reduced the risk of urinary incontinence and ED. Discuss erectile dysfunction, treatment and nursing care. Discuss culture and erectile dysfunction and pharmacy capsule. Erectile dysfunction is the inability to produce and maintain an erection for sexual intercourse and can be devastating for a man and his partner. Inadequate erection requires intact neurologic function, sufficient inflow of blood to fill the corpus cavernosa, and leak-proof storage mechanism for maintaining the erection. Factors that contribute to ED and related treatments will be summarized. Factors related to ED. Psychologic factors: depression, fear, grief, anxiety, interpersonal problems with partner. Psychotherapy, marital therapy, group therapy, sex therapy may be used for treatment. Medical conditions: cardiovascular disease, diabetes, stroke, osteoarthritis, Parkinson's, back pain, chronic obstructive pulmonary disease. Management of underlying condition can solve the erectile dysfunction in this case. ED drug therapy, vacuum therapy, penile implant, adaptation of sexual practices to accommodate disabilities may also be used. Medical and surgical interventions, medication side effects, pelvic radiation, perineal surgery, ostomy, mastectomy. Alternative drug therapy, counseling, ED drug therapy, vacuum therapy, penile implant, adaptation or sexual practices may be used as treatment. Lifestyle, tobacco use, excessive alcohol intake, lack of physical conditioning, obesity may contribute to erectile dysfunction. Minimize or cease use of tobacco and alcohol. Regular exercise and weight control can help. Contributing factors. A number of vascular, endocrine, neurologic, and psychological factors can cause or contribute to erectile dysfunction. Vascular disorders, systemic or local changes in blood flow, can impair the ability to achieve erection. Generalized atherosclerosis may be a factor in inadequate filling of the corpus cavernosa. Many modifiable factors contribute to the development of atherosclerosis. These include high cholesterol levels, smoking, excessive alcohol consumption, illicit drug use, and inadequate exercise. The cavernosa artery in the perineum between the scrotum and the anus may be damaged by physical injury to the pelvis, falls on the crossbar of a bicycle, horseback riding, or other blows. Significant damage to the artery limits the inflow of blood to the corpus cavernosa. Endocrine disorders that affect sexual function include DM and low testosterone. Patients with DM are at risk for erectile dysfunction because of atherosclerosis and autonomic neuropathy. Autonomic neuropathy is the dysfunction of some aspect in the autonomic nervous system, which is essential to the normal sexual response. Approximately 50% of men who have diabetes, regardless of type of treatment, develop erectile dysfunction, making diabetes the most common cause of erectile dysfunction. Diabetes is believed to interfere with blood supply to the penis when arterial walls lose flexibility or distensibility as a result of hardening of the arteries. Atherosclerosis may be accelerated by diabetes. Our dynamic neuropathy in patients with diabetes affects the ability of nerves to relax the smooth muscle surrounding the tiny sinuses of the erectile chambers. Without relaxed muscle tone and expansion of the sinuses, adequate filling with blood for an erection may not be possible. Effective management of DM is always desirable for general good health, but maintenance of strict blood glucose levels has not been shown to reduce the incidence of ED. Although the primary cause of ED related to diabetes mellitus is physiologic, the psychological reaction to the problem is an important factor. Cognitive behavioral therapy may be used to teach the patient to manage negative thinking. Vascular surgery to clear blocked arteries is not usually recommended for people with diabetes because they often have complicating problems with nerves, cells, erectile tissue, and blood vessels throughout the penis. A penile implant may be recommended for a patient with failure to initiate or failure to fill. As many as 1/3 of penile implant patients have diabetes. Phosphodiesterase type 5 inhibitors such as sildenafil, Viagra, and tadalafil, Cialis, are oral drugs that may be effective. Papaverine plus phentolamine self-injection is indicated as a treatment for failure to initiate or fail and has widely been accepted by patients. Alprostadil is available in an injection form and as a pellet that is inserted into the urethra. Patients need training on self-injection and must have hand dexterity and adequate vision. Neurologic disorders, spinal cord injuries and other neurologic disorders may cause ED. Communication between the spinal cord and the penis remains intact. The penis becomes erected with direct stimulation. For the penis to remain erect, smooth muscle relaxation is necessary and relies on communication between the brain and the spinal cord. The more complete the injury and the lower the injury, the more likely it is that an erection will be affected, even though higher injuries tend to cause more paralysis and loss of sensation. In addition to spinal cord injuries, perineal and rectal surgery may damage nerves involved in erectile function. Treatment of ED related to spinal cord injuries or neurologic disorders such as multiple sclerosis may include phosphodiesterase type 2 inhibitors, papaverine, or alprostadil, vacuum constriction devices, or penile implants. Medication side effects. Medications used to treat a variety of conditions may cause or contribute to ED. Drugs used to reduce high blood pressure are the most likely to interfere with erection. If systemic hypertension is accompanied by blockages and stiffening of the arterial walls of the penis, antihypertensive that lower blood pressure in all arteries of the body may reduce BP in penile arteries and to the extent that failure to fill occurs. Digoxin, which is used to treat heart conditions, may increase levels of estrogen and decrease levels of testosterone. Medications for stomach ulcers, such as cimetidine, and anti-cancer drugs may decrease libido, and anticholinergics and antihistamines may block neurotransmitters that relax the smooth muscle. Treatment of MDD related to these drugs may include changes in drugs or dosage, but such changes can be made only on a physician's order. Counseling or sex therapy, vacuum constriction devices, drug therapy, or penile implants may be appropriate for these patients. Psychologic factors. The psychological aspects of ED are extremely important and should be included in medical history. Psychogenic ED is most often the result of anxiety about performance. Problems may arise with aging, sexual beliefs or behavior, communication, changes in lifestyle, changes in medications, or chronic or poorly managed diseases. Anxiety may cause constriction of smooth muscle tissue in the penis and its arteries, and reducing inflow and increasing outflow of blood from the penis. Sex therapy that includes behavior modification techniques may be used to restore potency. Complementary and alternative therapy, Siberian ginseng and ginkgo biloba are herbs that some people believe increased penile blood flow. Scientific validation is lacking. Therapies that may be used alone or with traditional medication to treat ED include acupuncture, aromatherapy, imagery, biofeedback, and progressive relaxation. Pharm capsule, antihypertensive drugs are among those most likely to interfere with erection. Drug therapy. Phosphodiesterase type 5 inhibitors, Viagra, dialysis, and vardenafil are examples. These oral vasodilators may be prescribed for failure to fill or store. They must be prescribed with care in patients and cardiovascular disease because of the risk of myocardial infarction turns out in death. They are contraindicated for patients with nitrate vasodilators or alpha-energic agonists due to risk of hypotension and cardiovascular collapse. Alprostadil can be used for intracarbonousal injection or urethral suppositories. It has been successful for some men. It is a vasodilator but produces a more localized effect on arterial filling and improves storage. Urethral pain and urethritis are possible complications. Papaverine, self-injection or intracavernosal popover may be recommended for failure to initiate, fill, or store or for psychogenic causes. Papaverine is injected with a small needle into the erectile chambers, with relatively little pain. Erection is achieved within 10 to 15 minutes and lasts 30 to 60 minutes. Papaverine acts on smooth muscles to relax arterial walls and erectile tissue, increase blood flow into the penis. Papaverine is often mixed with phentolamine, which blocks the constriction tissue. Testosterone replacement for men with low hormone levels may improve libido, but is unlikely to improve ED. Vacuum constriction devices. Vacuum constriction devices may be prescribed for failure to initiate, fail, or store, or for psychogenic causes. The flaccid penis is slipped into a cylinder, and then the patient squeezes a pump that removes all of the air from the space within the cylinder around the penis. This creates a vacuum that draws blood into the penis. When the election has been achieved, a rubber ring is slipped off the bottom of the cylinder onto the penis near the base, trapping the blood safely for about 30 minutes. When air is again allowed into the cylinder can be removed. Revascularization. Revascularization is a surgical procedure that bypasses blocked arteries, removes or ties off incompetent veins, and tightens the surrounding tissue. The procedure is commonly considered experimental. Penile implants. Penile implants may be prescribed for patients with failure to initiate or failure to fill or store, and for some patients with psychogenic problems that are not appropriate for or responsive to counseling or sex therapy. Semi-rigid implants are silicone cylinders replaced by the erection chambers that keeps the penis firm at all times, but without increasing circumference. Rigid models can be bent downward but still may not be easily concealed under clothing. Hydraulic implants have cylinders that can be inflated by squeezing a pump in the scrotum or at the end of the penises between the glands. The pumping action causes the cylinders to fill with fluid from a reservoir in the abdomen or the scrotum. These implants more closely duplicate the natural erection. Nursing care. Assessment. The nursing assessment of a man with ED includes a health history that elicits information about the frequency of intercourse and satisfaction of sexual relations. The LPN may collect data that contributes to the complete assessment. The interviewer should not assume that sexual activity is no longer important to older adults. ED may be the first sign of diabetes. Surgical procedures, injuries, illness, cancer, and medications used regularly should be recorded. The patient's habits and lifestyle, including daily activities, diet, and use of alcohol and drugs, exercise, lifestyle, healthcare, interpersonal relationships, capability for self-care, age, physical condition, and educational needs should be explored. Listen and be careful not to dismiss the issue as unimportant. Provide factual information and resources. If you are not well informed about EDU, should refer patients to the physician, APN, or counselor. Cultural considerations, beliefs and values related to sexual function, as well as acceptable forms of sexual expression, are largely learned in one's culture. If a cultural belief is that older adults lose interest in sex as their abilities decline, older adults may try to act accordingly. That is, they may accept erectile dysfunction as normal and not seek treatment. Discuss Peyronie disease, Priapism, phimos and phimosis, infertility and treatment. Peyronie disease. Peyronie disease is the development of a hard, non-elastic, fibrous tissue, plaque, just under the skin on the dorsal surface of the penis. The plaque develops spontaneously or as a result of an injury. It interferes with the ability to fill during an erection. The plaque is usually located on the dorsal midline surface of the penis and results in an upward bending of the penis during erection that may be painful and interfere with successful vaginal penetration. Figure 54.2. The choice of treatment for Peyronie disease depends on the size of the plaque and the curvature and resultant degree of dysfunction. A variety of drugs have been used with varying degrees of success. Radiation therapy has been used, but many experts in the United States do not recommend it. Surgical correction involves excision of the plaque. Priapism. Priapism is a prolonged, unwanted penile erection that may be classified as low flow or high flow. Low flow priapism is very painful. It is a medical emergency because it may lead to ischemia of the penis, gangrene, fibrosis, and ED if not treated promptly. Urine flow may be obstructed, causing hydronephrosis. Priapism is associated with many factors, including sickle cell crisis, injury to the penis, leukemia, and malignant tumors. Drugs that may be responsible include cocaine, phosphodiesterase type 5 inhibitors, sildenafil, vardenafil, tadalafil, avanafil, and papaverine, plus phentolamine intracavernosal injections. Immediate removal of blood may be accomplished by aspirating blood from the erectile chambers or by injecting drugs that cause contraction of smooth muscle, inhibiting inflow of blood and allowing outflow. If these efforts fail, emergency surgery may be needed. Nursing care must be particularly sensitive to the embarrassment the patient may experience. Understanding the condition and alleviating pain are important. Phimosis and paraphimosis. Normally the penile foreskin in the uncircumcised male can be retracted, exposing the glands. Uncircumcised men need to retract the foreskin for cleaning as part of daily hygiene. As a result of poor hygiene, the foreskin may become inflamed and swollen, preventing retraction of the foreskin. This condition, called phimosis, is treated with antimicrobial agents and proper cleansing. Circumcision is sometimes recommended to prevent recurrences. Paraphimosis is just the opposite in that the foreskin is retracted and cannot be moved over the glands. Constriction of the penis causes the glands to swell. If the foreskin cannot be reduced to cover the glands, surgical intervention is necessary. Infertility. Infertile is a term used to describe couples who have had unprotected intercourse over a 12-month period and have been unable to become pregnant. Infertility may be caused by a reproductive problem in the man, the woman, or both. Cause and risk factors. Male infertility may be related to endocrine disorders, testicular problems, or abnormalities of the ejaculatory system. Correction of endocrine disorders may restore fertility. Infections can affect testicular and ejaculatory function. Structural factors that can affect testicular function are cryptorchidism, testicular torsion, and varicocele, dilation of the veins that drain the testes. Drug therapy, radiation, substance abuse, and environmental hazards can also affect the testes. In addition to infection, the ejaculatory mechanism can be disrupted by obstruction and some surgical procedures. Infections. Destruction of the seminiferous tubular epithelium results in failure or reduced ability to produce sperm. Mumps may result in acute orchitis and epididymitis, accompanied by fever and debilitating pain, bilateral swelling, and redness of the testicles. If damage to seminiferous epithelium occurs, the size of the testes will be reduced. Other infections such as tuberculosis, pneumonia, and syphilis may affect the testes, but less dramatically than mumps. Genitourinary tract infections can cause infertility in men. Chlamydia trachomatis is sexually transmitted and is most prevalent in young adults with multiple sex partners. The infection is most commonly limited to the urethra and causes varying degrees of painful urination and discharge. Progressive infection may include the epididymis and prostate gland. Neisseria gonorrhoeae is a common urethral infection in the United States. It is sexually transmitted and may cause extremely painful urination and a purulent discharge. Infections that ascend to the epididymis may result in decreased fertility. Cryptorchidism. Cryptorchidism is defined as any testis located in other than a dependent scrotal position. It is a common congenital condition, being found in approximately 30% of preterm male infants and in 1% to 3.4% of full-term male infants, figure 54.3. Although genetic disorders can cause cryptorchidism, the cause is usually unknown. Because the abdominal cavity is warmer than the scrotum, excessive warmth can damage the seminiferous epithelium of undescended testes and result in decreased spermatogenesis. Medical treatment. Cryptorchidism must be corrected within the first 18 months of life to give the best chance for fertility. Men with undescended testes have a 10 to 30 times higher incidence of testicular cancer than men whose testes descended normally. The risk remains higher even if the condition is subsequently corrected. If the testes are within the normal path but do not descend or cannot be pulled into the scrotum, they usually do not respond to hormonal therapy, and surgery is needed. Whether medical or surgical therapy is indicated, It is performed after the first birthday and before the second birthday. Untreated bilateral cryptorchidism results in sterility. Unilateral cryptorchidism may result in a low sperm count, but spermatogenesis continues and pregnancies are sometimes initiated without difficulty. Testicular torsion. Testicular torsion occurs when the spermatic cord twists, cutting off the blood supply to a testicle, figure 54.4a. It most commonly occurs in adolescence. Symptoms are intense pain, often accompanied by nausea and vomiting. If it does not resolve spontaneously, emergency surgery is required to untwist the cord and restore blood flow. If the testicle is deprived of blood for more than 4 hours, it may become necrotic and require removal. After testicular torsion is corrected, lowered sperm counts and infertility may follow. Varicocele. A varicocele is a lengthening and enlargement of the scrotal portion of the venous system that drains the testicle, see figure 54.4b. Varicoceles are caused by incompetent or absent valves in the spermatic venous system, which allows pooled blood and the resulting increased pressure to dilate the veins. Most often, only the left testicle is affected. Affected testicles may be smaller and may have reduced spermatogenesis. Varicoceles are a factor in about half of male infertility cases. Treatment includes surgical ligation or injection of a sclerosing agent into the dilated vein. Varicoceles may reappear after surgery and fertility may or may not improve. Vasectomy. Vasectomy is the surgical removal or tying of a portion of the vasa deferentia for sterilization purposes, figure 54.5. Erection, ejaculation, and intercourse are unaffected. Vasectomy is usually performed as an outpatient procedure in a physician's office or outpatient clinic. Postoperative pain or swelling can be managed with application of an ice bag, mild analgesics, and scrotal support. The patient can resume intercourse as soon as he feels comfortable, but it is important that he uses other methods of birth control until analysis of the semen determines that a complete absence of sperm exists. The patient can expect the analysis to be done after about 15 ejaculations post-vasectomy. The physician should explain the procedure, but the nurse can tell the patient what to expect and reinforce postoperative self-care. Although a vasectomy can sometimes be successfully reversed, it should be considered permanent. The reversal procedure, in which the severed ends of the vas deferens are anastomosed, surgically joined, is called a vasovasectomy. The nurse should be sensitive to the readiness of the male patient to undergo this procedure. Fears related to postoperative loss of sexual function may cause anxiety in some men, even though they desire the procedure. Acceptance and reassurance are important. Discuss penile cancer, testicular cancer, treatment and nursing care. Penile cancer. Cancer of the male reproductive system may arouse the worst fears about sexual dysfunction, disfigurement, and diminished self-esteem. Rare in the United States. Risk factors: not being circumcised in early life, especially if phimosis is present, infection with some types of human papillomavirus, HPV, or human immunodeficiency virus, HIV, and smoking. Cancer may appear as a shallow ulcer or dry, painless growth on the penis that is easily confused with a wart. It can be removed surgically if treated in early stages. Growths in advanced stages may ulcerate and involve the foreskin and penile shaft. Extensive resection or amputation as well as resection of nearby lymph nodes may be necessary. Radiotherapy or chemotherapy may be used for advanced cases. Testicular cancer occurs most often in young men between the ages of 15 and 35 years. Among the risk factors for this type of cancer are cryptorchidism, a genetic abnormality, HIV infection, and acquired immunodeficiency syndrome, AIDS. A painless palpable mass or enlargement of one testis is the most common symptom of testicular cancer. A feeling of heaviness and pain in the testicle occurs as the tumor grows. Young male Caucasians are at highest risk for testicular cancer. Self-examination and early diagnosis offer the highest chance of finding early-stage disease and subsequent cure. Self-examination includes monthly examination of the penis, scrotum, and perineal area. The individual should use a mirror to visualize areas that he cannot see and look for any changes from normal, such as swelling, lumps, tenderness, lesions, asymmetry, discoloration, or discharge. The examination is best done after a warm bath or shower, when he is warm and the scrotum is relaxed. The scrotum is held in the palm of his hands with the index and middle fingers on the underside of the testicle and the thumb on top. Each testicle is palpated between the thumbs and forefingers of both hands, with the testicle rolled gently between the fingers. The left testicle is usually lower than the right. The testicles are egg-shaped and should feel firm but not hard and smooth, without lumps. The epididymis, located on the top and posterior side of each testicle, feels soft and spongy. The spermatic cords are smooth, firm, tubular structures that run upward from the testicles on the back side. Diagnostic procedures include ultrasound and blood studies to measure tumor markers, alpha-fetoprotein and human chorionic gonadotropin. If the diagnosis is in doubt, surgical exploration is done. Radiographs, computed tomography, CT, scans, and bone scans may be done to assess for metastasis. Treatment for testicular cancer is designed according to the type of cancer and the stage. Treatment options are orchiectomy, i.e., surgical excision of the testis, radical orchiectomy, radiation, and chemotherapy. If treated in stage 1, orchiectomy alone is curative for most patients. If desired, a testicular prosthesis may be placed at the time of orchiectomy or later. Follow-up includes monitoring tumor marker levels and abdominal and chest scans for a period of 5 years from diagnosis. Treatment of testicular cancer may affect fertility and erections. The physician will inform the patient of the option of banking sperm before treatment begins. Interventions. Anxiety. From the time cancer is suspected, the patient faces anxiety-producing threats to self-image and self-esteem. You must be sensitive to the patient's fears of altered sexual function, loss of fertility, stressful treatments, and the threat of a potentially fatal disease. You can help the patient through listening actively, providing information, and referring him for counseling if needed. The patient may wish to have a significant other included in interactions with you and other health professionals. Pain. The amount of postoperative pain will vary with the type of procedure done. Assess pain with each vital sign check and take steps to treat it promptly. In addition to analgesics, you can use other pain control techniques such as mental imagery and relaxation exercises. Impaired urinary elimination. Radical orchiectomy usually requires a short hospitalization and has few complications. Nevertheless, monitor the patient's urinary status to confirm normal function before discharge. If the patient has a radical retroperitoneal lymph node dissection, he probably will have a catheter immediately after surgery. Potential for injury. Some patients with testicular cancer undergo radical retroperitoneal lymph node dissection. These patients have extensive surgical incisions and usually need intensive nursing care initially. As with any major abdominal surgery, the patient is at risk for shock, infection, bowel and bladder dysfunction, and fluid and electrolyte imbalances. Shock can result from fluid loss and the effects of anesthesia during the lengthy surgery. Measure and evaluate vital signs and fluid intake and output. Monitor the patient's electrolyte levels and administer intravenous fluids as ordered to maintain fluid and electrolyte balance. The patient is likely to have a urinary catheter in place and a nasogastric tube attached to suction. Constipation. Palpate the abdomen for bowel or bladder distension and auscultate for bowel sounds. When permitted, encourage ambulation, increased fluid intake unless contraindicated, and a diet with adequate fiber to promote bowel elimination. Administer stool softeners as ordered. Low self-esteem and body image disturbance. The patient may or may not be rendered sterile as a result of the treatment used. Radical orchiectomy results in sterility but does not impair erection and orgasm. If radiotherapy is used, the patient's sperm count typically declines at first, but usually returns to normal by 2 to 3 years after treatment is completed. The effects of chemotherapy on fertility vary with the drug used. Retroperitoneal lymph node dissection often causes ED and problems with ejaculation. Help the patient to formulate questions for the physician about the effects of specific treatments on sexual function and fertility. If sterility is anticipated, the patient should be counseled preoperatively about the possibility of banking sperm for future use. Because this type of cancer commonly affects young men, the potential to father a child at a later date may be very important to them. Lack of knowledge teaching is essential to prepare the patient for treatment and to provide the tools needed for him to cope with the diagnosis. The patient teaching plan will vary greatly with the extent of the cancer and the type of treatment given. Include the type of therapy prescribed, the side effects, the management of side effects, and available resources. Discuss drug therapy for male reproductive system and 10 NCLEX pharmacology questions from Pharmacology Reproductive/maternity webor medications. Androgen, testosterone. Oral preparations. Methyltestosterone. Methydist, Testred. Floxamisterone. Anroxy. Intramuscular preparation. Testosterone cypionate. Depotestosterone. Transdermal patch. Androderm, transdermal gel, androgel. Testim, Fordesta. Transdermal underarm. Solution, Axiron, implantable pellets. Test Opal. Buccal system, Striant. Treats hormone deficiency caused by developmental disorders, testicular diseases, or removal of testicles. Increases testosterone level. Retention of water, sodium, potassium, and chloride. Jaundice, GL distress. Increased effects of anticoagulants and oral hypoglycemics. Androderm patches may irritate skin. Buccal tablets may irritate the mouth and gums. Gels and underarm solution can be transferred to others via intimate contact. Females should not have contact with these. Assess for hypertension and edema. IM injections should be given deeply in the gluteus muscle using the Z-track technique. Androderm patches are applied to the arm, back, abdomen, or thigh, not to the scrotum. Androgel and Testim can be applied to the upper arm and shoulder. Androgel can also be applied to the abdomen, none should be applied to the scrotum. Axiron is applied to one or both armpits each morning. Pellets are implanted subcutaneously. Drugs for BPH. 5-alpha reductase inhibitors, finasteride, Proscar, ditasteride, Avodart. Alpha-1 adrenergic antagonists, blockers tamsulosin, Flomax, doxazosin, Cardura, terazosin, Hytrin, silodosin, Rapaflo, alfuzosin, urixatrol. Reduce prostate size, which decreases urethral obstruction. Effects not evident for several months. Relaxes smooth muscle in bladder neck, prostate capsule, and prostatic urethra, which reduces urethral obstruction. Decreased ejaculate volume and libido. Decreases PSA, which must be considered in interpreting PSA screening results. Teratogenic for male fetus. Doxazosin, terazosin, alfuzosin, lower BP, dizziness, sleepiness. Silodosin and tamsulosin, abnormal ejaculation. All, risk of complications of cataract surgery. Females who are or might become pregnant should not handle medication with bare hands or be exposed to patient's semen. Tell patient that effects are not immediate. Therapy must be continued lifelong to maintain benefit. Monitor BP. Caution with other drugs that lower BP. Tell patient if changes in ejaculation may occur. Testosterone inhibitors. Flutamide, Ulexin. Bicalutamide, Casode, Nilutamide, Nilandrin. Aberelix, Planaxis. Flutamide, Ulexin. Bicalutamide, Casode, Nilutamide, Nilandrin. Aberelix, Planaxis. GL distress, hepatotoxicity, gynecomastia, ED, hot flashes, edema, hypertension, anxiety, confusion, mental depression. Liver function must be monitored. Do not double up if a dose is missed. Be sure patient understands that drug must be taken with LHRH, advise of effects on sexual function. Tell patient to report GL distress, pain in right side, dark urine, yellowish color of skin or sclera. Gonadotropin-releasing hormone agonist. Luprolide, Eligard, Luprin. Viator. Triptorelin, Trelstar Depot, Trelstar LA. Goserelin, Zolacard. Luprolide desensitizes pituitary receptors for GnRH, testosterone release rises at first, then declines. Used for advanced prostate cancer. May be given with an androgen receptor blocker to reduce adverse effects. Hot flashes, impotence, loss of libido, reduced muscle mass, increased adipose mass. May cause increased pain initially, usually resolves over time. Luprolide can be given daily, subcutaneously, monthly or quarterly, IM, or yearly, implant. Triptorelin given IM monthly or quarterly. Goserelin comes as a pellet that is injected into the upper abdominal wall with a 16-gauge needle. A local anesthetic may be given first. Drugs for ED. Sildenafil, Viagra, Vardenafil, Levitra, Tadalafil, Cialis. Relaxes smooth muscle in corpus cavernosum, which increases blood flow with subsequent erection. Tadalafil is available for PRN or daily use. Headache, dizziness, abnormal vision, diarrhea, dyspepsia, priapism, UTI, flushing, rash. MI, sudden death, cardiovascular collapse, especially if taken with organic nitrate therapy. Numerous other contraindications including MAO inhibitors, severe hepatic or renal impairment, pregnancy or lactation, not recommended for women at this time, history of coronary artery disease, CHF, dysrhythmias, or stroke. Many interactions, refer to a drug handbook when administering. Do not take if taking organic nitrates, example, nitroglycerin, combination can be fatal. Drug is only effective with sexual stimulation. Patients over age 65 may be started on the lowest dose and increased if necessary. If on PRN tadalafil, instruct patient to take 1 hour before sexual activity and not to take more than once daily. Other drugs. Estromostine, MCIT, a hybrid of estrogen and an alkylating agent. Palliative therapy for prostate cancer. Gynecomastia, HF, thrombosis equals MI or stroke, fluid retention, nausea, vomiting, diarrhea, hypercalcemia. Monitor for HF, dyspnea, edema, fatigue, inform patient not to take with milk/high calcium food. Discuss chapter key points and questions, and evolve questions. KEYPOANTS. The male reproductive system consists of the scrotum, testes, epididymides, vasa deferentia, seminal vesicles, prostate gland, ejaculatory duct, Cooper glands, internal urethra, and penis. Prostatitis is an inflammation of the prostate gland that is treated with antimicrobials, analgesics, and sitz baths. Epididymitis is an inflammation of the epididymis that is treated with bed rest, cold packs, sitz baths, analgesics, antibiotics, and scrotal support. Benign prostatic hyperplasia, enlargement of the prostate gland that may lead to obstruction of the urethra, may be treated with drugs or surgical intervention. Nursing care after prostatectomy addresses risk for deficient fluid volume, acute pain, risk for infection, risk for injury, urge urinary incontinence, sexual dysfunction, situational low self-esteem, and deficient knowledge. Erectile dysfunction, impotence, the inability to achieve or maintain an erection adequate for sexual intercourse, may be treated with psychologic intervention, oral drug therapy, vacuum constriction devices, self-injection therapy, intraurethral pellets, or penile implants. Nursing care of the patient with ED may focus on sexual dysfunction, situational low self-esteem, and ineffective self-health management. Peyronie disease is the formation of fibrous tissue in the penis that causes it to bend upward during erection, causing pain and interfering with vaginal penetration. Priapism is prolonged penile erection not related to sexual desire that requires emergency treatment to prevent ischemia, gangrene, fibrosis, and future ED. Infertility is the inability to impregnate despite unprotected intercourse over a 12-month period. Causes of infertility include endocrine or testicular dysfunction and disorders of the ejaculatory system. Cancer of the male reproductive system may affect the penis, testicles, or prostate gland. Nursing care of the patient with testicular cancer focuses on anxiety, acute pain, risk for injury, impaired urine elimination, constipation, situational low self-esteem, and deficient knowledge. Other disorders affecting the male reproductive system are hydrocele, phimosis, and paraphimosis. Discuss 20 NCLEX question from Adult Health, Reproductive. The nurse is collecting data from a client with epididymitis. The nurse would expect to note which signs and symptoms of this problem: fever, nausea and vomiting, and painful scrotal edema. Typical signs and symptoms of epididymitis include scrotal pain and edema, which often are accompanied by fever, nausea and vomiting, and chills. The nurse is providing a teaching session to an adolescent female regarding sexual maturation. The nurse recognizes that successful teaching has occurred if the adolescent female makes which statement: breast changes most commonly occur before growth of pubic and axillary hair. Clinical findings associated with sexual maturation typically occur in an orderly pattern. Breast changes usually occur before the development of pubic and axillary hair. The nursing student is assigned to care for an adolescent female client in the healthcare clinic, and the instructor reviews the menstrual cycle with the student. The instructor determines that the student understands the process of the secretion of follicle-stimulating hormone, FSH, and luteinizing hormone, LH, if the student makes which statement. FSH and LH are released from the anterior pituitary gland. FSH and LH are released from the anterior pituitary gland to stimulate follicular growth and development, growth of the Graafian follicle, and production of progesterone. A client with chlamydial infection has received instructions on self-care and prevention of further infection. The nurse determines that the client needs further teaching if the client states which: I will use an antibiotic prophylactically to prevent symptoms of chlamydia. Antibiotics are not taken prophylactically to prevent acquisition of urethritis from chlamydia. The nurse is teaching an adolescent female about menstruation. Which statements, if made by the adolescent female, demonstrate a need for further teaching? 1. The average duration of menstruation is 3 days. 2. The day of ovulation is counted as the first day of the menstrual cycle. Which statements made by the nursing student accurately reflect correct information about the hormone oxytocin? 1. It can cause contractions of the uterus during and after birth. 2. Oxytocin is used primarily for labor induction and augmentation. The nurse is assisting in planning a teaching session with a client diagnosed with urethritis caused by infection with chlamydia. The nurse would plan to include which point in the teaching session? The most serious complication of this infection is sterility. The most serious complication of chlamydial infection is sterility. The nurse is caring for a client with a possible ectopic pregnancy. The nurse would perform the following actions in which priority order. 1. Assess the client for signs of increased pain or vaginal bleeding. 2. Obtain a urine specimen. 3. Prepare the client for ultrasound. 4. Assess the emotional state of the client. The nursing student is asked to describe the size of the uterus in a non-pregnant client. Which response indicates an understanding of the anatomy of this structure? The uterus weighs about 2 ounces. Before pregnancy, the uterus weighs approximately 60 g, 2 ounces, and it has a capacity of about 10 milliliters, 0.34 Oz. The nurse is conducting a session on the process of fertilization with a group of nursing students. The nurse asks a nursing student to identify the structure in which fertilization of an ovum takes place. The nurse midwife recognizes the teaching has been effective if the student selects which location. Fallopian tube. Fertilization occurs in the fallopian tube. A maternity nurse is providing an in-service educational session to nursing students regarding the process of conception. The nurse determines that successful learning has occurred if the nursing students correctly identify which statements as true. 1. The blastocyst usually implants in the anterior or posterior fundal region. 2. Fertilization of the mature ovum occurs in the distal third of the fallopian tube. 3. Human chorionic gonadotropin is the hormone needed for a positive pregnancy test. The nursing instructor asks the nursing student about the physiology related to the cessation of ovulation that occurs during pregnancy. Which response by the student indicates an understanding of this physiological process? Ovulation ceases during pregnancy because the circulating levels of estrogen and progesterone are high. Ovulation ceases during pregnancy because the circulating levels of estrogen and progesterone are high, thus inhibiting the release of follicle-stimulating hormone and luteinizing hormone, which are necessary for ovulation. A client who has been seen in the clinic has been diagnosed with endometriosis and asks the nurse to describe this condition. Which is the best response for the nurse to provide? Endometriosis is the presence of tissue outside the uterus that resembles the lining of the uterus. Endometriosis is defined as the presence of tissue outside the uterus that resembles the endometrium in structure and function. The licensed practical nurse, LPN, is assisting a school nurse in conducting a session with female adolescents regarding the menstrual cycle. The LPN tells the adolescents that the most likely day for ovulation in a 30-day menstrual cycle is which day? Day 16. The normal duration of the menstrual cycle is about 28 days. However, in a longer menstrual cycle, ovulation typically occurs 14 days before day 1 of the next cycle. 30 days minus 14 days would be day 16. The nurse is caring for a 45-year-old client. The client has 3 healthy children, all born via spontaneous vaginal birth. The client has been diagnosed with mild uterine prolapse and asks the nurse what she can do to prevent further prolapse. The nurse would include which instructions in the teaching plan? 1. Lose weight. 2. Eat a diet high in fiber. 3. Perform Kegel exercises. 4. Take a stool softener daily as needed. A client has been examined in the clinic and has been diagnosed with pelvic inflammatory disease. The client asks the nurse to describe this condition. Which description of pelvic inflammatory disease by the nurse is accurate? Pelvic inflammatory disease is an infectious process that involves the uterine, tubes and uterus. Pelvic inflammatory disease, PID, is an infectious process that most commonly involves the uterine, fallopian, tubes, salpingitis, and uterus. The maternity nurse is describing the ovarian cycle to a group of nursing students and asks a nursing student to identify the phases of the cycle. Which phases stated by the nursing student indicate a need for further teaching in this area? Select all that apply. 1. Secretory phase. 2. Proliferative phase. The ovarian cycle consists of 3 phases: preovulatory, ovulatory, and luteal. The secretory and proliferative phases are part of the endometrial cycle. The nursing instructor asks a nursing student to list the functions of the amniotic fluid. The student responds correctly by stating that which are functions of amniotic fluid. 1. Allows for fetal movement. 2. Is a measure of kidney function. 3. Surrounds, cushions, and protects the fetus. 4. Maintains the body temperature of the fetus. The maternity nursing instructor asks a nursing student to identify the hormones that are produced by the ovaries. Which hormones identified by the student indicate an understanding of the hormones produced by this endocrine gland? 1. Estrogen. 2. Progesterone. The ovaries are the endocrine glands that produce estrogen and progesterone. Oxytocin is produced by the posterior pituitary gland and stimulates the uterus to produce contractions. LH and FSH are produced by the anterior pituitary gland. TSH is produced by the thyroid gland. A nursing student is asked to identify the layers of tissue found within the uterus. Which student responses are correct with regard to the tissue layers of the uterus? 1. Myometrium. 2. Perimetrium. 3. Endometrium. The tissue layers of the uterus include the myometrium, perimetrium, and endometrium. Discuss the other 7 questions from Adult Health, Reproductive and the worksheet for Clayton CH40 drugs to treat men and women health.
A patient is being started on a combination oral contraceptive. You are to provide her with the initial health teaching regarding the prescription. What would you explain? Instructions for using combination oral contraceptives. Start the first pill on the first Sunday after period begins. Take one pill daily, at the same time, until the pack is gone. If using a 21-day pack, wait 1 week and restart on the next Sunday. If using a 28-day pack, start a new pack the day after finishing the last pack. Full protection by the pill during the first month may not occur, so the use of an additional form of birth control, condoms, foam, during the first month is advised. If the product prescribed also contains an iron supplement, be sure to take the 7 inert tablets monthly. The iron supplement is in the 7 inert tablets, not the 21 tablets containing hormones. Many women skip the inert tablets each month, thinking that they have no benefit. Missed pills. Take the pill as soon as a missed pill is remembered. Take the next pill at the regularly scheduled time. If 2 pills are missed, take 2 pills as soon as remembered and 2 pills the next day. Spotting may occur when 2 pills are missed. Use another form of birth control, condoms, foam, until the pack of pills is finished. If 3 or more pills are missed, start using another form of birth control immediately. Start a new pack of pills on the next Sunday even if menstruating. Discard the old pack of pills. Use other forms of birth control through the next month after missing 3 or more pills. Missed pills and skipped periods. Return to healthcare provider for a pregnancy test. Skipping one period but not missing a pill. It is not uncommon for a woman to miss a period occasionally when on the pill. Start the next pack on the appropriate Sunday. Spotting for 2 or more cycles. See the healthcare provider. A dosage adjustment may be necessary. Periodic examinations. A yearly examination should include blood pressure tests, pelvic examination, urinalysis, breast examination, and pap smear. Discontinuing the pill for conception. Because of a possibility of birth defects, the pill should be discontinued 3 months before attempting pregnancy. Use other methods of contraception for these 3 months. Duration of oral contraceptive therapy. Many healthcare providers prefer to have patients discontinue the pill for 3 of every 28 months. This allows the body to return to a normal cycle. Be sure to use other forms of contraception during this time. Long-term use, 3 or more years, must be determined on an individual basis. Serious adverse effects to be reported as soon as possible. Severe headaches, dizziness, blurred vision, leg pain, shortness of breath, chest pain, and acute abdominal pain. Although these adverse effects are usually of minor consequence, a more serious condition must be ruled out. Note, when being seen by a healthcare provider or a dentist for other reasons, be sure to mention taking oral contraceptives. A 22-year-old patient comes to the clinic for an annual physical examination and renewal of her oral contraceptive prescription. She tests positive for chlamydia and becomes very upset when informed of this. How would you manage this situation? Address the client's concerns. Provide full attention and use physical touch. Explain confidentiality of facility. Assess level of anxiety and adaptive responses and coping mechanism used. When a patient is being initiated on phosphodiesterase inhibitors, what pre-assessment screening should be performed? Identify specific drug classifications that should be determined when performing a medication history for a male patient with erectile dysfunction. Obtain baseline vital signs and a history of recent use of medicines, including recreational drugs. Patients with cardiovascular disease should seek their HCP approval before starting phosphodiesterase inhibitor therapy. The use of antihypertensives in men with erectile dysfunction should be determined. Discuss important premedication assessments to be used with all types of contraceptives. Premedication assessment. Review the medical history. If there is a history of obesity, smoking, hypertension, gallbladder disease, diabetes mellitus, severe varicose veins, seizure disorders, oligomenorrhea or amenorrhea, rheumatic heart disease, thromboembolic disease, stroke, malignancy of breast or the reproductive system, renal or liver disease, severe mental depression, suspected pregnancy, or repeated contraceptive failure, consult with a healthcare provider before dispensing birth control pills. Take a baseline body weight measurement, along with blood pressure measurement in the supine and sitting positions. Pregnancy, or repeated contraceptive failure, consult with a healthcare provider before dispensing birth control pills. Ensure that a pregnancy test has been given and that the patient is not pregnant. A patient is being started on a transdermal contraceptive. You are to provide her with the initial teaching regarding the contraceptive. What do you explain? Instructions for using transdermal contraceptives. A new patch should be applied on the same day of the week. This day is known as patch change day. The patch should be applied to clean, dry, intact, healthy skin on the buttock, abdomen, upper outer arm, or upper torso in a place where it will not be rubbed by tight clothing. Patches should not be placed on red irritated skin or on the breasts. Patches should not be cut. Topical products such as makeup, powder, lotions, or creams should not be applied to the skin or to the patch area because the patch may not adhere properly and absorption of the hormones may be impaired. Select one of the following methods. First day start. Apply the first patch during the first 24 hours of the menstrual period. Note on a calendar the day of the week as a reminder of patch change day. If the patch is started after the first 24 hours of the menstrual cycle, a non-hormonal backup contraceptive, condoms, spermicidal foam, diaphragm, should be used concurrently for the first consecutive days of the first cycle. Sunday start. Start the first patch on the first Sunday after menses begins. A non-hormonal backup contraceptive, condoms, spermicidal foam, diaphragm, should be used concurrently for the first 7 consecutive days of the first cycle. If a patch is partially or completely detached. For less than 24 hours, try to reapply the patch in the same place or replace it with a new patch immediately. No backup contraception is necessary. Patch change day will remain the same. Do not try to reapply the patch if the adhesive will not adhere to the skin. Do not use other adhesives or tape to hold a patch in place. Apply a new patch in a different location. For more than 24 hours or if not sure how long since detachment, because there may be a lack of protection from pregnancy, stop the current contraceptive cycle and start a new cycle immediately by applying a new patch. This is a new day 1 and a new patch change day. A non-hormonal backup contraceptive, condoms, spermicidal foam, diaphragm, should be used concurrently for the first 7 consecutive days of the new cycle. If a woman forgets to change the patch. At the start of any patch cycle, week 1 day 1 there may be a lack of protection from pregnancy. Apply the new patch as soon as it is remembered. This is a new day 1 and a new patch change day. A non-hormonal backup contraceptive, condoms, spermicidal foam, diaphragm, should be used concurrently for the first 7 consecutive days of the new cycle. In the middle of the patch cycle, week 2 day 8 or week 3 day 15. For up to 48 hours, apply a new patch immediately. The next patch should be applied on the usual patch change day. No backup contraception is needed. For more than 48 hours, because there may be a lack of protection from pregnancy, stop the current contraceptive cycle and start a new 4-week cycle immediately by applying a new patch. This is a new day 1 and a new patch change day. A non-hormonal backup contraceptive, condoms, spermicidal foam, diaphragm, should be used concurrently for the first 7 consecutive days of the new cycle. At the end of the patch cycle, week 4 day 22 the patch should be removed as soon as the woman remembers to remove it. The new cycle should be started on the usual patch change day, which is the day after day 28. No backup contraception is needed. Switching from oral contraceptives to the patches, apply a patch on the first day of the menses. If there is no withdrawal bleeding within 5 days of the last active hormone tablet, after day 21, a pregnancy test should be completed to ensure that there is no pregnancy before the patch is started. Missed patches and skipped periods. Return to the healthcare provider for a pregnancy test. Skipping one period but not missing a patch. It is not uncommon for a woman to occasionally miss a period when receiving hormone therapy. Start the next cycle on the same patch change day. If 2 consecutive periods are missed, a pregnancy test is in order. Contraceptive therapy should be discontinued if pregnancy is confirmed. Spotting for 2 or more cycles. See the healthcare provider to have other causes of bleeding assessed. Periodic examinations. A yearly examination should include blood pressure tests, pelvic examination, urinalysis, breast examination, and pap smear. Serious adverse effects to be reported as soon as possible: severe headaches, dizziness, blurred vision, leg pain, shortness of breath, chest pain, and acute abdominal pain. Although these adverse effects are usually of minor consequence, absence of serious adverse effects such as thromboembolism or ectopic pregnancy must be confirmed. Note: when being seen by a healthcare provider or a dentist for other reasons, be sure to mention that hormonal contraceptives are being taken.